If you would like to claim continuing education credit for attending today's session, register with CDC's Training and Continuing Education online system and search the course number on the screen for the Hospital Sepsis Program Core Elements webinar series.
Thank you for joining us for the third installment of our Hospital Sepsis Program Core Elements webinar series. Before we begin, I have 3 disclosure slides to show related to the CE that's being offered through CDC's Training and Continuing Education online system. We will advance through them slowly to allow you time to read. The first is the following accreditation statement. This webinar is accredited for CME, CNE, CEU, CHES, MCHES, CPE, and CPH. I will now share with you the following disclosure statement from CDC. CDC, our planners and presenters wish to disclose that they have no financial relationships with ineligible companies with the exception of Dr. Erica Kaufman-West, and she wishes to disclose within the last 24 months that she was on the Speakers Bureau for Gilead and AbbVie for hepatitis C. All relevant financial relationships listed for these individuals have been mitigated, and she has divested her financial relationships with all ineligible companies. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept financial or in-kind support from any ineligible company for this continuing education activity. I will now share the following joint accreditation statement for pharmacy education. Please take a moment to read on your own. Thank you. Again, welcome to the Centers for Disease Control and Prevention's Project First Line Hospital Sepsis Program Core Elements webinar series. This 5-part series will explore the nuances and details of the new Hospital Sepsis Program Core Elements. These core elements will help U.S. hospitals implement, monitor, and optimize institutional sepsis programs and improve sepsis outcomes. They complement existing sepsis guidelines and help facilitate the implementation of guideline-recommended care practices at a wide variety of hospitals and healthcare systems in the United States. I'm Erica Kaufman-West, the Director of Infectious Diseases at the AMA. As you know, anyone can get an infection, and almost any infection can lead to sepsis. Sepsis is the body's extreme response to an infection. The CDC estimates that about 1.7 million adults in the United States develop sepsis each year, and at least 350,000 of them die each year because of it. The key to improving sepsis outcomes is early recognition and prompt treatment, requiring everyone's vigilance. We've put together this in-depth series to look closely at important elements that facilities can use to build robust sepsis programs. Each 1-hour webinar will discuss key features of effective sepsis programs and include examples from CDC partners, sharing strategies, real-life examples, and best practices for successfully implementing one or more program core elements. Today is the third of the 5 webinars, and we will focus on action. Specifically, action refers to what we, as clinicians, do to recognize and treat sepsis. It's creating a screening process, standardizing treatment through tools like an electronic order set, and developing processes to provide prompt delivery of appropriate antimicrobials. Action is also working on fluid and effective handoffs between healthcare professionals and training rapid response teams to recognize and intervene when patients develop sepsis, including utilizing a code sepsis protocol. Peri-discharge and post-discharge patient care are also essential in helping patients recover and in helping their families cope with possible long-term consequences. We will highlight key pieces within this element so we can be sure that our sepsis programs are effective at improving the treatment and outcomes of patients with sepsis. Our 3 panelists today will bring examples of successful implementation of the action core element at their institution and what it might look like in different facility settings. We will try to answer some live questions as well as some questions that were submitted during registration so that we can make this program tailored to your interests. We'll try to answer as many questions as we can. Rest assured, those that we cannot get answered, we will try to put into a resource document that will be here when the video is done today. I'm honored to introduce our sepsis expert, Dr. Hallie Prescott. Dr. Prescott is an associate professor of internal medicine at the University of Michigan and a physician at the Ann Arbor Veterans Affairs Healthcare System. She is internationally recognized expert in sepsis management and outcomes. She serves as the co-chair of the Surviving Sepsis Campaign Guidelines and physician lead for the Michigan Hospital Medicine Safety Consortium's Sepsis Initiative. She will explain what the Action Core element is and what is needed to develop a sepsis program that leverages the various tools we have to prevent, recognize, treat, and assist in the recovery of patients with sepsis. Dr. Prescott?
Great. Thanks so much, Dr. Coffin-West. It's my pleasure to present today. This slide has disclosures, and I'll just pause a moment to let people read. Next slide, please. So this slide shares some data that was gathered from the 2022 NHSN annual survey that was completed by over 5,000 hospitals. And this provides a sort of a baseline state of affairs of where things stand with hospitals currently. From this survey data, we learned that 73% of hospitals currently have a sepsis committee or a broader committee that is charged with addressing sepsis management and outcomes in their hospital. But a quarter of hospitals are yet to have a committee to address this. We also found that when you do a deeper dive into these existing committees, that there are potential opportunities for improvement. For example, we found that only 55% of hospitals provide dedicated time to their hospital sepsis program leaders. This means that sort of people with already a lot of things on their plate are being tasked to address sepsis on top of everything else. And we know that that means that this is a task that may kind of fall off the plate as people get too busy. So we think having dedicated time for sepsis program leaders is an important area for growing sepsis programs going forward. Another example is that we found that only 55% of hospital sepsis programs involve collaboration with antibiotic stewardship programs. Sepsis is a condition that requires coordination across disciplines and across specialties in the hospital, and antibiotic stewardship programs are just one example of groups that should be interacting with the hospital sepsis program. So overall, the good news is that we found that the majority of hospitals already have a sepsis committee, but there are certainly opportunities for improvement in terms of the structure and organization and resources of those committees. Next slide. So the background or the purpose for the Hospital Sepsis Program core elements is really to provide high-level guidance on monitoring and optimizing hospital sepsis management and outcomes of sepsis, essentially a manager's guide of how to build a successful hospital program to monitor outcomes and improve outcomes over time. Some of the key things that are emphasized in this guidance are securing leadership support. We know that high-level sort of leadership buy-in from hospital leaders is important to ensuring that hospital sepsis programs have the necessary resources and engagement to do the work they are tasked with. We also know that these committees require engagement of multi-professional hospital staff and need to work with quality improvement tools and implementation science to ensure that the initiatives are having their intended effect and are improved over time to ensure that they are optimally effective. This guidance is meant to complement, not replace, but complement existing sepsis guidelines to facilitate the implementation of recommended best practices for sepsis. Another key sort of important thing to note about the Hospital Sepsis Program core elements is that they focus very broadly on management of sepsis throughout the hospitalization, from that very early first presentation into the emergency department all the way up to discharge, setting our patients up to have long-term recovery after hospitalization. This guidance is intended to be relevant and applicable to all hospitals in the United States, regardless of size, setting, location. We were very mindful in the development to try to ensure that there was flexibility in terms of how these programs are implemented and how they're run, recognizing the diversity of hospitals in our country. Next slide. The materials provided with the launch of the Hospital Sepsis Program core elements include the guidance on the left. A self-assessment tool in the middle. This allows hospitals to go through and see how are things currently at their hospital and identify next steps to develop or further improve their hospital sepsis program. And on the right, we have a high-level infographic summarizing the 7 core elements included in the hospital sepsis program core elements. Next slide. This infographic also summarizes the core elements. The first, as I touched on prior, is the importance of hospital leadership commitment in terms of supporting the hospital sepsis program activities. Accountability, which has 2 components. The first is ensuring that there is an identified leader or 2 co-leads of the hospital sepsis program, and that the hospital sepsis program is setting concrete objective goals for the success of the program, and that progress towards those goals is monitored regularly, and that those goals are updated periodically, such as annually, to continually push for further improvement in the management and outcomes of sepsis over time. The next element, multi-professional expertise, discusses the importance of engaging all of the many relevant stakeholders across the hospital or hospital system. Action is the focus of today's webinar, and this talks about having structures and processes in place to help support clinicians in delivering evidence-based recommended best practices for sepsis. The next 2 elements, tracking and reporting, go hand in hand. This refers to measuring outcomes, management, impact of hospital sepsis interventions, and then reporting those back to relevant stakeholders. And the final element is education, and this referred to broadly education of hospital staff, as well as patients, families, and caregivers. Next slide. So I'm now going to go into some more detail about the action core element. For each of our core elements, we provide examples that are priority examples, sort of what we think are the more important examples of things that hospitals can do to meet this core element, as well as additional examples. So priority examples for action include having a standardized process to screen for sepsis. And we know that this is not going to be a one-size-fits-all. The process at your hospital is going to depend on things like the size of your hospital, the type of patients in your hospital, the resources available. But one thing that's important for all hospitals is to ensure that this process is well integrated into the existing clinical workflow to make sure that this happens consistently for every patient. The second thing we point out in this example is that it's important to consider for newer tools, such as machine learning tools, to not project bias by gender, race, or ethnicity in the rollout of these algorithms. The next priority example is having a hospital guideline for management of sepsis that addresses key aspects of management, including screening, clinical evaluation of patients at risk for sepsis or with suspected sepsis, diagnosis of sepsis, antimicrobial selection and de-escalation, source control, patient and caregiver education, as well as recovery-based practices to set up patients for longer-term recovery and best outcomes after sepsis. Next slide. Additional priority examples include having a hospital order set for the management of sepsis to make it easy to do the recommended practices, having structures and processes to facilitate prompt delivery of antimicrobials, which we know is a key aspect associated with better outcomes from sepsis. So some specific examples of things that hospitals can do to facilitate prompt delivery of antibiotics after they are ordered is to stock common antimicrobials in high-use locations, such as the emergency department or intensive care unit, having processes to immediately process the new antimicrobial orders in patients with sepsis, having order sets that default to having the first administration of antibiotics occur immediately, as opposed to defaulting to sort of the next routine, Q12-hour administration time, and then having pharmacists on site in key locations outside of the pharmacy, such as the emergency department and ICU. Finally, having structures and processes in place to support effective hospital handoffs in patients with sepsis. We know that patients undergo many transitions over the course of their hospitalization, for example, transitioning from emergency department to inpatient wards, ICU to wards, or even between providers as they rotate on and off service. We also know that these transitions are high-risk periods where things can fall through the cracks. And so it's really important to have structures and processes in place, such as standardized handoff processes or documentation templates, to ensure that the key information is passed on and care can be delivered in a seamless fashion to our patients. Next slide. Additional examples of action include having rapid response teams that are trained specifically in recognition and early management of patients with sepsis, having a code sepsis protocol. This is essentially having a huddle of key providers, doctor, nurse at the bedside of the patient who, flags positive for potential sepsis, so you can huddle, evaluate the situation, make a group decision of whether sepsis is most likely, and if so, initiate early management steps. Another example is having a peri-discharge evaluation to support recovery, evaluating for new limitations that are common in our patients after sepsis, reviewing chronic conditions, reviewing medications, screening for social vulnerability, and connecting patients to available resources. Post-discharge care coordination. We know that many patients after sepsis need ongoing care, and it's really important to get this care in a timely fashion. Scheduling those follow-ups prior to discharge and trying to organize these in a way that it's most feasible for our patients to attend those visits, or even having dedicated post-sepsis or post-critical illness follow-up clinics where many of the care can occur in a centralized location are ways to help facilitate recovery in our patients after sepsis. Finally, having structures and processes in place to prevent the development of healthcare-associated infections, which contribute to hospital onset sepsis. Thank you.
Thank you, Dr. Prescott, for outlining the core elements broadly and then for detailing the action element more specifically for us. Before I introduce our panelists, I'd like to invite you to enter your questions for the presenters in the chat box on your screen. We will answer as many questions live as we can, and some presenters will be typing in answers to your questions, so be sure to check the Q&A box and see if your question has received a written response. Also, please note that if the graphics on the slides or in the video appear blurry, please increase your screen's resolution by clicking on the bars in the bottom right of the video player and selecting a higher quality setting. Now, let's hear from our panelists who will discuss how they implemented the action element into their sepsis program. First, I'd like to introduce Dr. Michael Phil.
Thank you very much. Oh, go ahead.
I was just going to say, sorry, I misplaced your bio here. So let me give a little background for the audience for you. Dr. Phil is board certified in emergency medicine and practices clinically as an emergency department physician for Henry Ford Health in Jackson, Michigan. He's a clinical assistant professor at Michigan State University College of Osteopathic Medicine. He's the current president of the Michigan College of Emergency Physicians, the current counselor for the state of Michigan, represented the American College of Emergency Physicians, and the physician champion and chair of the Henry Ford Health Jackson Hospital Sepsis Committee. Dr. Phil will focus on early recognition of sepsis and how a well-defined process can improve the identification of these patients. Now, Dr. Phil.
Thank you very much. We can go ahead to the next slide. So Henry Ford Jackson Hospital is located in Jackson, Michigan, which for those who are not familiar is in South Central Michigan. Our city population is about 31,000 and the county population is 160,000. It's a 420-bed hospital, level 2 trauma center with approximately 70,000 emergency department visits a year, which sounds quite high for a community of that size, but we're the only hospital within about 35-mile circumference. So we have a very large catchment area. And we see about 1,400 sepsis cases every year. So if you could go to the next slide. When we first started tackling sepsis, we empowered our nurses in the emergency department to advance and draw lactates. So we have a nurse-driven protocol where if the patient we call it screens positive, meaning they have any of the two following SIRS criteria, which you can see listed on the right of your slide, that they actually order a lactate and send it up to the lab. Now, pending the value of that lactate, if it's greater than 2, they call the physician assigned to that patient and have a huddle like Dr. Prescott was talking about. So ideally, this occurs at the bedside, but sometimes we all know that that's not possible given if people are busy or what have you. So it's at least a phone call. And the 3 things that we discuss are the IV fluids, the antibiotics, and the next steps for the patient. One thing we noticed when we first implemented this protocol was that we were still having quite a delay in antibiotic administration. And so one of our residents actually did a little project on that and found that many of the antibiotics that we were using weren't actually located in the Pyxis. They had to come from pharmacy. So what we did was we identified the most common antibiotics and made sure they were in our bedside Pyxises so that they could be administered relatively quickly. So if you could go to the next slide. So this is a copy of a paper form that we implemented to kind of outline the process that I just described. And these are sitting around in our emergency department. The nurses can pick one up, one of the physicians could pick one up. And if you could go to next slide, I zoomed in on a little bit because I realized that might be kind of difficult for people to see. So you can see there's a little checklist on the front of the sheet there that kind of takes you through the SIRS criteria. You could go to the next slide. Thank you. And if patients have organ dysfunction and kind of what the next steps are. If you go to the next slide, you can see the back of the sheet. And this part of the sheet is meant to go with the patient. So it actually has times and kind of next steps. And there's areas for the nurse to initial things to show, kind of check them off, if you will, as you go. Next slide. And you can kind of see how it takes you really basically through the 3-hour bundle as you go down that sheet. If you go to the next slide, one of the more recent things we've done is I get a lot of questions from our physicians. What am I supposed to do in this situation? So we actually borrowed this from one of our other facilities that I spoke with on the phone and came up with this little flow diagram that kind of takes you through a little bubble diagram of the step 1 bundle and what the next steps are. So there's kind of yes and no and where to go and your next steps, orders, etc. And you can't see it on this slide, but on the actual document, we have a lot of EPIC dot phrases. We use EPIC for our documentation system. Those dot phrases are listed right on this sheet. So for the various steps, the physicians can hit the appropriate documentation phrases that we want in the chart. If you go to the next slide, there is my contact information. I realize that's fairly dangerous to do on a webinar like this, but please feel free to reach out to me afterwards with any emails, questions you may have, and I'm happy to share any of this information or forward any of these documents on to you. So thank you.
Thanks, Dr. Phil, for sharing your order sets and some of the details about how this worked at your facility. Our second presentation is a joint presentation by 2 of our panelists. Dr. Megan Cahill earned her Bachelor of Science degree at the University of Michigan and her Doctor of Osteopathic Medicine degree from Michigan State University College of Osteopathic Medicine. She's a trained emergency physician and now the Division Chief of Medicine at Henry Ford Macomb Hospital, where she led the hospital sepsis program as a physician champion. Her co-presenter is Erin Cook. Erin received her BSN from Oakland University School of Nursing. She is the HMS Sepsis Abstractor for Henry Ford Macomb Hospital. She is responsible for sepsis data abstraction and is involved in quality improvement initiatives at her local hospital. Prior to joining, Erin worked as a registered nurse on Henry Ford Macomb's medical telemetry unit. Their presentation will illustrate the importance of discharge coordination for complex sepsis patients.
Thank you so much for the introduction. Again, I'm Dr. Megan Cahill. I'm from Henry Ford Macomb in Clinton Township, Michigan. I'm going to give you a little bit of an overview of our hospital to level set a little bit of our current practice and our patient population. So we're a community hospital in Southeast Michigan. We have 366 licensed inpatient beds. We are a level 2 trauma center and a primary stroke center. We're also nationally recognized cardiovascular center of excellence. Recently, we opened a North Tower that has 160 acuity adaptable beds. You can see the picture of our beautiful North Tower on that lower picture that we're quite proud of. We are affiliated with Michigan State University, and with which we have 8 graduate medical education residency programs that span between surgical specialties, medicine specialties, as well as outpatient family practice. We have a pluralistic medical staff model at our hospital. We have both private and employed provider groups. So the intricacies of pluralistic medical staff does lend to some challenges with discharge planning that we will go into a little bit in the presentation. Just to give you an idea of our sepsis volume, for 2022, we had a sepsis volume of discharged patients with a diagnosis of sepsis of over 1,700 patients. The breakdown of that is over 950 sepsis diagnoses, 272 severe sepsis diagnoses, and then 479 septic shock diagnoses. So we certainly take care of a pretty high volume of critical care patients with sepsis. Next slide, please. So this is just a quick overview of the 3 main elements that are working together for best discharge to home care coordination for our sepsis patients. So the 3 elements all need to work together in tandem for this to be a successful discharge process. The first element here is the case management team. This is our inpatient case management providers that work in the hospital setting. They will help determine if the patient needs assistance in scheduling their outpatient primary care appointments upon discharge. Then they would connect with the hub, which is external to the hospital. It's part of Henry Ford Health's population health division, and there are coordinators within that population health that will help schedule the PCP appointments post-hospital discharge for our patients with the diagnosis of sepsis. And then the patients themselves are obviously integral to this process. They will receive all the appointment information and education that they need upon discharge. Next slide. So just diving into each of these elements a little bit more thoroughly, the case management team will receive a referral either directly from a consult from a physician, or they'll receive a referral from the nurses working bedside on their daily rounds with our case management and social work teams. Upon referral receipt, the case management team will then go and assess the patient, and they will determine with the patient if they need any assistance in making their PCP follow-up appointment upon discharge. If that is the case and the patient does accept that assistance, then the case management team will then consult with the hub and indicate the patient's primary care physician. And then they will rank the patient's readmission risk. It's part of the order that's placed to the hub. And they will either assign the patient as low risk, medium risk, or high risk. Sepsis in and of itself is considered a high risk readmission rate. So they will be deemed as a high risk. Next slide, please. So when we look at the hub, this is a system-wide group of population health coordinators. They work with all of our hospitals within Henry Ford Health, with the exception of Jackson at this time. So all of our Southeast Michigan sites. They are the ones responsible for calling the primary care doctor's offices for our patients and scheduling those follow-up appointments. The high-risk appointment or the high-risk patients that are deemed on the case management consult will have that follow-up appointment scheduled within 7 days of hospital discharge. If the patient doesn't have an established PCP already assigned, then the hub will work with the case management team and that patient to help identify an appropriate primary care physician for follow-up to ensure that they can help them establish a PCP and a follow-up appointment within that 7-day window. Now, if the hub team is unable to successfully schedule that follow-up appointment, then the hub will contact the patient within 72 hours upon discharge from the hospital to reconnect with them and see if they need any additional assistance, or if they've been able to, in the interim period of time, make an appointment to help coordinate that with the patient. Next slide. The patient then will receive their discharge instructions, which we call our after visit summary. That will include, if the hub is able to make that appointment, it'll include the follow-up PCP appointment date and time on those discharge instructions. If the hub was unable to make that appointment for the patient, it'll list that, stating that the patient still needs to call their PCP for a follow-up appointment within the next 7 days. On our after visit summary, we also list the hospital contact number. So the patient has a lifeline back to the hospital to reach back out if they have any issues or concerns that arise between the time they're discharged and when they're able to follow up with their primary care physician, so we can continue to assist them in that interim period of time. We do have a specialized sepsis education guide that was created through our system sepsis committee that is about to go live. It was supposed to go live within the last week or so, but it got pushed back just a little bit longer. But it's a very robust guide that's very patient-centered and very patient-friendly, that gives the patient and their family members and loved ones further explanation of what to look out for upon discharge and warning signs that would prompt them to seek medical care sooner than their scheduled appointment with their PCP. And then the patient themselves will receive a phone call within 72 hours from the hub if they were unable to schedule that appointment prior to discharge, to reconnect with that patient and see what additional support they may need. Next slide. So this is a really quick overview of how those three elements all work together. We did implement this hub process in 2020, and from 2020 to 2023 current state, we have shown a statistically significant decrease in our sepsis readmission rates, which may likely be contributed to this process. However, we also are very mindful that COVID happened in 2020, and there's external factors that also likely contributing to sepsis readmission rates that we can't completely account for in that model. So if there's any other questions, we'll be happy to provide any other explanations during the live Q&A. Thank you.
Thank you both for deconstructing the complex discharge process of these sepsis patients and showing how all of these moving parts need to work together for maximum patient benefit. So I'd like to start the conversational portion of this event with a question from one of the participants watching today. The first one is for Dr. Phil. Dr. Phil, this is from Jennifer Sanchez. Is the code sepsis called overhead and worked up similar to a code blue to help facilitate the care and interventions for the patients?
Thank you for that question. Actually, we do not call it overhead. We call it through our Halo system, which Halo is like a secure text messaging system. So that goes to the charge nurse, or clinical unit leader, as we call it. It goes to the pharmacy, and it also goes to a few other members of our team. And it prompts the nurse and the physician to get together. And usually it's just the nurse and physician working with that patient directly that participate in the huddle and the code, if you will, to go over the next steps. Now, the reason we involve the clinical unit leader in that process as well is the clinical unit leader usually has the bandwidth to follow up with the bedside nurse and assist her or him if they need any other things, like if they need antibiotics, if they need an additional IV, etc. Hopefully that answers your question.
Thanks for that. I've got a question now for Dr. Cahill. Who among your care team is responsible for fielding phone calls when the patient calls back after discharge?
Yeah, thank you for that question. I know that that's a topic that's come up at many conversations, especially even recently at HMS yesterday. So on our discharge instructions, the phone number that's provided is to our hospital operator. And then that operator is the one responsible for then sending it to the appropriate person for response.
Great, thank you for that. One came in from Michelle. I'll open this up because it's not for a specific panelist. What is the best way to gain physician support for sepsis bundle elements? For example, fluid resuscitation is sometimes difficult to obtain compliance due to concern for fluid overload in patients that have heart conditions such as CHF.
Yeah, that's a great question. I can sort of start off and other people can chime in. I think it's probably a combination of two things. One, sort of providing the evidence that exists in terms of published literature, but also this tracking and reporting of outcomes in your own hospital. So for example, there's a paper that was published about a sepsis bundle initiative that was rolled out in Kaiser Permanente, Northern California, and they were implementing sepsis bundles, including this 30 ml per kg fluid resuscitation in all patients with hypotension or a lactate over 2. And there was concern, as concern often comes up, about people with a history of heart failure or chronic kidney disease. And so they tracked those patients really closely. And interestingly, they found actually those were the patients that had the greatest mortality benefit as this initiative rolled out. But being able to sort of provide that data back from your own hospital, I think, is really powerful. So.
Thanks, Dr. Preston. Anybody else? Yeah.
Sure. I'll jump in. And Dr. Cahill knows we've emailed each other back and forth because we work in the same system, and we've asked this question back and forth. So one of the things I've done is exactly what Dr. Prescott said, is gone with that literature and taken it to the providers and tried to show them, yes, there is a mortality benefit. One of the things I've always said to my providers as well is, I typically send them back these cases when they don't get enough fluids or what have you. And I say, look how many of these cases I send back to you, and look how many M&Ms we have where the patients get too much fluid. And it's really disproportionate, right? And so I think that hits a nerve. Another thing we've been successful at, and I think people are going along with this, is looking up old echocardiograms. I don't know what everybody's system is like on their documentation and whatnot, but I've encouraged people, and this seems to help, to look and see when the patient's last echo was, even if they do have a diagnosis of CHF, because sometimes it'll be diastolic heart failure and their EF will actually be preserved, and people are more comfortable in that situation giving IV fluids.
Yeah, I agree. And just to add on an additional perspective too, I think it's important to also make sure that your physicians are realizing that the majority of times when patients do have congestive heart failure or end-stage renal disease, they're often kept at a very dry weight, and they are not usually euvolemic, they're usually hypovolemic. So when they get into a state of sepsis or septic shock, they're even more in need of the excess fluids because they're kept at such a dry weight to begin with.
Thanks for all those practical, helpful tips. Another one I'll send toward the physician's way. There's a question from Vicky. Dr. Phil, you had touched upon using lactate and then the antibiotics and IV fluids as a part of sort of that initial sepsis recognition and bundle. Vicky asked about vasopressors and where that role is, and is that essential to get in the first hour, or is that something that can come a little later?
Yeah, that's a good question. So the bundle really encourages the fluids within the first 3 hours and whatnot. But I believe, and correct me, the other two physicians that are on the line, is that early vasopressors are better in these hypotensive septic patients. One of the things we've really stressed, and which has really gotten our vasopressor use earlier, is we went with a nursing protocol that allows for pressors to be administered through a peripheral IV for the first at least 12 hours. I believe they actually extended up to 24 hours. And really going out to the nursing staff and educating on that, they're very much more comfortable with starting them peripherally. And many times we've actually found that our ICU colleagues have gotten on board with this, and they don't even require central line placement. After a few hours of pressors, they actually come off once they've been truly resuscitated.
Yeah, I completely agree with that. There's been growing data that's come out over the past couple of years showing that it is safe to administer vasopressors through peripheral IVs, particularly if it's for short periods of time and they're being closely monitored. And so we've seen, across the state of Michigan, an increase in that. And I do think it is important to couple that, with a nursing protocol to monitor, identify any extravasation or leaking of the vasopressor out and sort of, address that immediately. But sort of with those in place, it is safe. And we do see that it avoids the placement of central lines in about a third of patients, right? Because many patients will only require vasopressors for a short period of times, and typically the sort of complication rate of central line is much higher than the complication rate of sort of short durations of peripheral vasopressors. So that is certainly something that I think can help in terms of getting vasopressors to patients quickly.
Great. Thank you. This next question, a couple of questions actually that came in for Dr. Cahill, all around the idea of sepsis discharge instructions. So I'll try to sort of put them together into one fairly cohesive question. One audience member was wondering if your hospital EMR already had sort of pre-created sepsis discharge instructions, or if you had to create those sort of from scratch yourselves, and sort of how that process worked of the creation of those discharge instructions.
Sure. Yes, we use Epic as our EMR system. We do have some templated sepsis discharge instructions. We felt as a sepsis program from the system perspective that we wanted to provide something that was a little bit more robust to our patients and maybe giving them some more of the early warning signs that preempted them to seek medical attention even prior to some of the triggers that were listed on our pre-templated sepsis discharge information that's provided on Epic. So we felt that this would be a more comprehensive view to give patients all of the early warning signs that they would be able to recognize at their home setting, that was a little bit more robust than what was pre-templated already in Epic.
Great. Erin, since you sort of work with Dr. Cahill, do you have any thoughts or sort of experience on how that process went, or sort of feedback on what other programs can do to build their own sepsis discharge instructions?
Yeah, so what happened was it pretty much was started by one of the other hospitals within the system. It was their sepsis coordinator and ours at Macomb. And then we brought in the other sepsis coordinators and the HMS sepsis abstractors. And then we all just kind of looked at what we had previously, like Dr. Cahill mentioned, as our discharge instructions. And then we just took that and added on to it. So it has a lot more information in it. And then hopefully this information is able to, the patients are able to leave the hospital knowing more about sepsis, knowing about how their life is going to be affected afterwards. And then we're hoping that'll help keep them, keep down our readmission rate also.
Great. I think really educating patients, but also their families, like you guys have been talking about, is really important to make sure that that they know what to expect and they're not these surprises that sometimes send them straight back to the emergency department. But if they just had a little bit of awareness, it would help everyone. So thank you for sharing. I have a question here about the SIRS criteria and the SOFA criteria. So I'll maybe start with Dr. Prescott and then see if the other physicians have an update. Is the SIRS criteria still in use for diagnosing sepsis, or has it been overtaken by SOFA, which is the sequential organ failure assessment?
Yeah, happy to speak to that. So, right, historically in our sort of prior expert consensus definitions for sepsis, SIRS was included in the actual definition of sepsis. And then in the most recent like sepsis 3 definitions published in 2016, they're no longer included in the definition. And I think the sort of rationale for that evolution is that SIRS criteria were felt to be perhaps more of a sort of normal or like healthy response to infection, where when you're getting to the point that you have acute organ dysfunction, this means like collateral damage has happened, and that is what defines sepsis. But I think the important point here is that SIRS criteria are still clinically helpful for identifying signs of potential infection. And all sepsis starts out as infection. So while it's not part of the definition, I think it's still very clinically helpful in terms of flagging people, at risk, just like as Dr. Phil was mentioning, is used in their sort of screening protocol and to trigger this code sepsis. So hopefully that kind of clarifies why it's not in the definition, but we still think it's clinically helpful and useful.
Yes, thank you. Another question that came in, and I'll sort of leave it to maybe Erin and Dr. Cahill's team. What steps for action have you implemented on the inpatient side that that we can utilize to implement at our own hospitals for the period from initial ED to ICU admission. So more that first sort of presentation of sepsis right from the door. There's this person, Janine, seems to have a gap from ED orders through that initial inpatient admission set.
Sure, and I have to imagine, Janine, that you may have some issues with ED boarding and ED boarding times, particularly to the ICU setting, as many of our hospitals, especially community sites, are struggling with right now. One of the ways, and Dr. Phil could speak to this as well, is part of the code sepsis process that we utilize through Henry Ford Health is having not only an initial huddle, but then a repeat huddle that we have with our patients at the 3-hour mark to kind of all come back together at bedside with the patient, the nurse, the physician, and the patient, and reassess where have we gone, what have we found, and what do we do next? And making sure that that happens regardless if there's an ICU order in and the patient's still bedded in that area, or if the patient's just about to go up to an ICU bed, that still is consistently done at the 3-hour mark to make sure that that patient doesn't have any gaps in care. Dr. Phil, I don't know if you have anything else additionally you want to add as well.
Sure. And one of the things we noticed kind of through this process, and I don't know if this answers your question or if it's even possible because I don't know what your model is we'd have a little bit of gaps in care sometimes when those patients would go up to the ICU, especially on those patients who maybe I would kind of call them tweeners. They're not exactly ICU appropriate, but maybe they're kind of a little bit uncomfortable for the hospitalist team to manage on like a step down unit. So what we've been encouraging, and our ICU team actually was great working with us, is if there are questions or, if the patient is really sick, to come down, actually have the intensivist. And we've had some success meeting with the intensivist at the bedside, having them evaluate the patient. And we have almost a 3-way huddle with our the bedside nurse, the ICU physician, the ER physician, and kind of talk about the goals of care and then what the appropriate next steps is. And when we do that, we seem to not have as many gaps in that care.
Thanks. What a great idea to get everybody right at the bedside and talking about it in real time. Erin, I wanted to put this question to you since we were talking previously about the discharge instructions and education for patients and their families. Have you been able to measure the impact or quantify if that education has helped discharge patients seek help sooner, or what sort of metrics have you been able to capture as to what that education has done for patients and their families?
So unfortunately, we haven't been able to present our guides yet. Like Dr. Cahill mentioned in the presentation, it kind of got pushed back. So we will be starting with it soon. And then hopefully, yes, we will have that education.
Great. Are you guys going to look at how many calls come in through the operator, or are you just going to sort of have an observation period, I guess, and sort of see what feedback you get?
Dr. Cahill, would you know the answer?
Yeah, I think that sparks some good questions we hadn't considered. That's a fantastic idea. And I definitely think that after this call, Erin and I are going to powwow and discuss what potential metrics we should look to capture as a result of this education. Thank you for that recommendation.
Great, thanks. I have a great question from Rosemary that I'll open up to the group because I think it's a really important one. Dr. Prescott talked initially in the overall sepsis core elements about equity and making sure that we're applying great care to everyone equally. So what considerations have you made around equity in your sepsis program in terms of people who are non-English speaking, unstably housed, limited access to transportation, et cetera? Because readmissions, as we know, tend to happen disproportionately in certain vulnerable populations. Anybody want to jump in on that one first?
Yeah.
So we actually, sorry, Dr. Prescott, within our hub process that Dr. Cahill was speaking about, we have another set that's within it, and it's our ambulatory case managers, and they're able to actually follow up with our patients within the medical group. And when they make those phone calls, another question they will ask them is about transportation issues. And if they have any, they will help set them up with transport to get them to and from their hospital appointments.
Yeah, I think the other thing you guys mentioned is that not only are you, setting up primary care follow-up appointments with physicians in your system, but also physicians outside your system, and then for patients who don't have a primary care physician working to identify them. So I think that's one key thing. The Surviving Sepsis Campaign guideline includes a strong recommendation about sort of systematically screening patients at discharge for various aspects of social vulnerability, so housing instability, transportation, lack of a primary care physician, and connecting to people to resources as able. And I think that's really key in terms of preventing readmissions and kind of setting people up on the right path towards recovery.
Appreciate that feedback. The next question has to do with that tricky notion of definitions, and one person's definition of sepsis or SIRS and acute renal failure versus acute respiratory failure. So this one has to do with the CMS sort of definitions, and folks want to know for Dr. Cahill, Dr. Phil, and Dr. Prescott, do your facilities follow the CMS SEP 1 definition as an institutional clinical guideline, or the SEP 3 definition? So back to the SIRS definition versus the SOFA definition, when you look at your clinical data and you say, this is how many septic patients we've had.
Sure, we use SEP 1, and it's a very good. I think it's a very good screening for us. And sometimes I get actually questions about, does that overscreen a little bit? And my answer to that is yes, it does. But typically, those patients are sick anyway. They might have a GI bleed, et cetera, and so they need some sort of intensive care up front, if you will. So I think it's actually very helpful to use a little bit of a broad net, and not only for sepsis care, but it kind of treats the more critical patients and identifies them a little bit early.
And I will just add on to that, as Henry Ford Health, we still do look at SEP 1 definitions because of the CMS, implications associated with them. However, with the Hospital Medicine and Safety Consortium that all of us are part of, all of Henry Ford Health, along with there's 69 total hospitals in the state of Michigan that all participate in this HMS collaborative together. We are looking at more refined and a little bit larger scope data of what our septic patients look like and what our septic patients' early predictors could be that go beyond what SEP 1 identifies currently. And Dr. Prescott is leading that work right now with HMS. So I think that we are a little bit more in tune also of what's maybe on the horizon of what's to come with sepsis and how the definitions may evolve, or the categorizations of severe sepsis and shock may change or be adapted to our new data that we're finding with our HMS work.
Thanks for that. And Dr. Cahill and Aaron, I know you haven't had those discharge instructions go live, but people are very interested in them. And this one I think is a good good thought. Are you all planning to provide that discharge education to all patients that have that diagnosis of sepsis? Only patients with severe sepsis, only ICU patients? Like, how are you quantifying who gets that education?
It is going to all sepsis patients.
Great. Another question that came in from Margaret. Again, Dr. Prescott had mentioned how these sepsis program core elements are supposed to be used in all types of facilities, rural, urban, suburban. And this is, I think, a good question to try to help, again, close that equity gap. Does anyone have advice for implementing a code sepsis or a sepsis RRT in a hospital with limited resources and staff?
I guess my thoughts would be that the code sepsis doesn't require additional sort of people beyond who's already there. It's really bringing together the people that are, the team players in terms of the sepsis management. It's bringing them together, which requires time up front, but I think saves time in the long run. So I don't know, Dr. Phil, maybe you can elaborate on that and sort of like the additional sort of time or resources that you guys needed to put into implementing the code sepsis work.
Sure. The code sepsis, I would say, is almost more attuned to the timeout we have for surgery. It's not really that long of a process. People get scared when we say code sepsis and you think of a medical code, which, typically is taking a lot of your time. But a code sepsis, most of these huddles, if you will, and code sepsises, I can accomplish in under 2 minutes. And it's really just talking. And a lot of times you'll find that you're already doing these things for the patient. It's just quantifying things like, oh, I already have fluids started on this patient, but I need to add additional fluids. Oh, we need to order our antibiotics. Oh, we need to draw blood cultures, etc. So it's not necessarily the time. And I think of it, like I said, like I'm more of a timeout tuned to pre-procedural sedation would be a good analogy in the emergency department.
And also, I feel like it's important to use the nomenclature of a code sepsis because it brings the awareness that a code sepsis is equally as important as a code STEMI or as a level 2 trauma or as other types of code scenarios. We know patients that have septic shock have a 25 to 30% mortality rate. These patients require prompt and early identification and treatment to prevent their progression of their disease. So using the word code or a sepsis alert doesn't necessarily need more resources, but it brings an extra awareness to the team that this is a priority patient. This is one of your sickest patients in the emergency department, and we need to have all eyes focused on this patient at this moment in time to get everything established for their best success of successful treatment.
Thanks, everybody. I just want to say thank you for such a great conversation and discussion. I'm going to close things out here with a summary. So prevention of infections that can lead to sepsis is key, as we've heard from our presenters. And facilities must work to follow proper infection prevention and control practices to avoid the spread of infections within the facility. Once patients have an infection, the prompt recognition through formal screening tools and a well-educated rapid response team can get patients started on effective treatment quickly. Electronic medical record systems should be leveraged for screening tools and for standardized workflows, including order sets. Effective sepsis treatment requires many different experts and team members to stay knowledgeable on guidelines, to work together and coordinate care across different hospital units, and continually strive for improvement in these areas. Lastly, we cannot forget that as patients near discharge, they and their families will likely need education and support. Many patients will require assistive devices and services as they work to regain strength and function. Screening for social vulnerabilities is essential so that patients can get the resources and care they need without feeling stigmatized. And finally, ensuring that the patient's primary care provider is aware of the patient's clinical course, along with any new diagnoses and medication changes, will help patients avoid readmission and stay on their recovery path. A recording of this webinar will be available on this page shortly. We have drafted a PDF of relevant links related to our important topic today that we hope you'll find helpful. You can locate this in the top left corner above the video in the Resources tab. Thank you for listening and for your dedication to learning how to reduce the morbidity and mortality associated with sepsis. We know that recognizing and treating sepsis requires a commitment of resources, of continued education, and of cooperation. By utilizing these core elements, all facilities can develop new sepsis programs and strengthen existing ones. We're excited to have you on this journey with us as we embark on this 5-part series. Part 4 in the series will be on November 16th at 1 p.m. Eastern Time, and we will examine the elements of tracking and reporting. In that session, we will look at how programs can define what metrics matter, how to report them efficiently, and how to communicate that data to the facility at large. The 5th and final episode will be on December 7th at 1 p.m. Eastern Time, and we'll look at the key role education plays in sepsis programs. We hope you will continue to send in questions with each webinar so we can tailor these sessions to what you find relevant. Thank you and have a great afternoon.